I started to see that sometimes we prescribe too much medication, which wasn't really necessary. This is common in my office today. Patients on many medications, I remove unnecessary ones.
I stop at least half of them.
It's not a joke, and he already gets a lot better just by stopping things there.
Only elderly people, right, brother?
And they keep taking a bunch of things they don't even need.
Hello, everyone. Welcome to Saúde, which is our new podcast about health, quality of life, and longevity. In this podcast, we will bring the top health experts from Brazil. Everything you need to live longer and better. Most importantly, it's about health. Living longer isn't meaningful without it. And today we have an amazing guest. We're going to talk about cardiology, we're going to talk about cholesterol, we're going to talk about supplementation, and we're going to talk about integrative medicine. That's right. The kind of medicine that really treats you and prevents you from getting sick. And it's with great pleasure that I welcome Dr. João Paulo Cimini, cardiologist, integrative physician, who has honored us with his presence here. Thank you very much, João Paulo, and welcome.
Thank you. Let's have a chat here. I hope it's amazing that we can reach everyone who's watching, right? Good tips and an easier interpretation of what we deal with every day in medicine, especially in cardiology and integrative medicine.
No, João Paulo, folks, he's a remarkable guy, you know? He's a guy who gives lectures all over Brazil, has a lot of knowledge, and sees patients. He doesn't have openings, okay, but he sees patients in Belo Horizonte. Maybe you'll get lucky and someone cancels. Then you can get an appointment with him. We'll give you his contact information at the end of this conversation. So stick around until the end, okay? This podcast, this conversation is unmissable. Before we start, João, I want to give you this special Nutriage supplement kit specially put together for you. It has everything I know you like. Here you go. Look, for cardiology, magnesium. It's all there. Look, for cardiology. Coenzyme Q10, K2, B with K2. We'll talk about that later.
Omega-3.
The omega with icosapentaenoic acid. Okay, 1,000 of icosapentaenoic acid.
Did you say coenzyme Q10?
Coenzyme A, Nutriage's coenzyme is with taurine. Very interesting.
And the ultra magnesium with 3 types.
3 types of magnesium.
That's really interesting.
Taurate, bisglycinate, and magnesium glycine.
Great.
Which one is your favorite? Great, favorite, it seems, right? Glycine?
I love it. I love it. Thanks for the gift.
And creatine for you, you know, to get that shape, huh?
With HMB, right?
With HMB and with taurine.
Tell us about HMB for the audience at home.
Man, HMB, hydroxymethylbutyrate, is incredible. It helps prevent catabolism. Because people who exercise don't want to lose muscle, so HMB, besides increasing your energy, will protect your muscle mass.
Look, since you mentioned it, I asked you to talk about HMB. The other day, I saw a patient who was taking HMB prescribed by a conventional doctor. There's someone from the industry, but I don't know which lab it is. They're already shifting heavily into supplementation, right? They've already opened up the market. So there are several supplements that are linked to big industries. And what about HMB? They created a line with HMB to treat frailty in the elderly in cases of sarcopenia. The family reported improved muscle mass, like absurdly.
It doesn't get better. Sensational. Look, creatine for seniors, we'll discuss that later. Creatine for the elderly is an almost mandatory supplement, exactly because of sarcopenia, right?
Yes.
To protect muscle mass. And combined with HMB and taurine, which will give that, because taurine is interesting, right? It gives that energy, helps with the mitochondria, with energy production. It also acts as a gamma-aminobutyric acid inducer, boosting gamma-aminobutyric acid production for relaxation. So it has this function, this double function. Really cool. I'm sure you'll benefit from these supplements.
Thank you.
And then you'll tell us if it's really good or not.
I'll give feedback later, but since it's from you, I'm sure it's good.
Amazing, guys. Let's go, guys. Let's start our chat. Well, first I wanted to know from you, why did you start in medical school? There you had contact with what we can call the classic knowledge of medicine. And I know that this has improved. I know that this has advanced. But in my time, I graduated in the 90s. So I graduated in 97. I'm giving it away. I already revealed my age by saying I graduated in 97. And I used to observe in general health education and in all health fields, there was a strong focus on treating the disease. So the patient, first, they would only look for a doctor when they had some pains, some symptoms, some problems, some disease. So the diabetic would only go to the doctor when diabetes was already present, and it was the same thing with hypertension. So at that time, I saw a Western perspective, and it was like that throughout the West, not just in Brazil, of treating the disease. Since you had that training as well, you came from a later group, you graduated much later. It was still that mindset of treating the disease, of treating, and even worse, treating the symptom, which is worse than treating the disease. And how did you come to see this more integrative approach? And how did you realize the need to treat the patient so that he wouldn't get sick? To protect health, which is much cheaper, much more interesting, and much better for the patient to treat him so that he doesn't get sick. Then later, having to treat the symptoms and all the problems that come with degenerative diseases. How was that your journey, your awakening?
Actually, I didn't wake up to this in college, about this in college, because what happens in college? We're in that environment and you just go along with it day after day. You go on autopilot, let's put it that way. In college, you basically just switch to autopilot. There are teachers there to teach, but you're not really putting it into practice, into real life. I really became aware of that. It was when I started seeing patients in my office. Then I finished college, worked for 2 years at a health clinic, worked in, let's say, in the countryside.
Which is the best school there is.
I worked for 2 years, 2.5 years. I saw patients in villages. I even saw patients at schools. There wasn't a health clinic, so I was at the school to see people. But at that time, it was interesting. It was a really cool learning experience. And then I went to Belo Horizonte to do cardiology. I finished cardiology, and I opened a clinic. Let's get started now.
That classic path.
Let's start my career now and see which path we're going to follow here. I said that before we started talking. After 6 months in cardiology, I was already discouraged. What was it? The patient would come in with high blood pressure and you give them medication for the blood pressure. Yes, the patient would come in with high cholesterol and you'd give them medication for the cholesterol. And then there was the AS, right?
Antiplatelets.
The antiplatelet, which used to be talked about a lot in terms of prevention. Recent studies, some conflicting but credible, suggest it may slightly increase bleeding in people without a history of heart attack or cardiovascular disease. But there's a part of the literature that says it's also good for prevention in lower doses anyway. We can discuss this later. After 6 months, it became exhausting, and I didn't think I could continue.
It became something automatic, right?
It turned automatic, a true cookie cutter recipe. So there are days, let's say in a whole day, I would see 20 patients. The blood pressure readings didn't change according to the patients. Most people go to the cardiologist. Why? Because they have high blood pressure or high cholesterol, or they've already had a heart attack. And they go there to renew a prescription and see if they'll continue with the medication or not. So after 6 months of seeing this, that cookie cutter prescription really bothered me.
That wasn't what you had in mind.
That wasn't what I thought. I thought that I, as a cardiologist, would make a much bigger impact on a person's life. Different from the hemodynamicist, right? The hemodynamicist, guys, is the doctor who does the catheterization, right? So if someone is having a heart attack, he goes there and opens up the artery that's having the heart attack. Man, I saved a life.
Yeah, it's already an acute case, right?
You get there and do that, it gives the guy some relief. One. Now, you as a clinician, when you're there, it's not urgent. You're there to improve the person's quality of life, to try to help the patient get better. With this acetylsalicylic acid, an antiplatelet, and cholesterol medicine, I couldn't do it. Right? We don't just go there, ask, how do you feel? And say, take this, goodbye. We chat, we want to know how your sleep is, how you're feeling. Look, doctor, I'm having a lot of body pain. I'm not feeling well. Look, I'm fatigued. My energy isn't good. I noticed that most people were overweight, fatigued, and tired. And I couldn't help them in any way because what I learned was only about cholesterol, right? It's true, high cholesterol is bad, but in cardiology, we mostly just talk about cholesterol. All my classes focused only on cholesterol. I didn't have any on other topics. So that started to frustrate me and made me leave where? My comfort zone. Because I said, no, I need to change the way I work. I need to help people get better. And I couldn't have studied medicine and then cardiology just to stay stuck in that. So in that, integrative medicine began to interest me. Even though I didn't know it was called integrative at the time, I started through YouTube videos, right? I started watching some doctors talking about some things and I thought, that makes sense. Oh, interesting. I didn't know that. I want to learn more. It sparked my curiosity, right? And that started opening doors, right? And then I started diving deeper into it and there was no turning back, right? Because I started seeing good results at the office, though some outcomes weren't as interesting as I expected. Later, with clinical practice, we begin adjusting based on experience, right? Later, we can even talk about that. Back then, I used a very low dose of magnesium for arrhythmias, and I got some results, but they weren't that good. Then, I started adjusting those doses and began to get fantastic results. So our office is about science, right? This is a science. It's a science that we're practicing. So there are people who say that magnesium doesn't work, that it's nonsense, that it's just a myth. No. It's for those who don't have experience with this and who haven't lived through it. Because from the moment you start prescribing, you start seeing the results. You see the amazing results. I began gradually incorporating this into my cardiology patients' daily routines. Then I started ordering an extra B12, some vitamin D, checking iron levels, because we don't learn to order these things. You look at the blood count in classical medicine to see if there's anemia in the hemoglobin or not, right? If there's no anemia in the hemoglobin, life goes on.
Ferritin at 400 doesn't mean anything, right?
And ferritin at 5 doesn't mean anything. Because if the hemoglobin is good, there's no problem. Everything's fine, even with ferritin at 4. The patient has good hemoglobin and no anemia on the blood test. Anemia and deficiency are different. He doesn't have anemia in the blood test, but he doesn't have iron in his body, so he's fatigued, he's tired. The thyroid doesn't work well. In women who notice, the hair starts to fall out and the nails become weak. So that was missing in my daily life. As a clinical cardiologist, I wanted to be both a cardiologist and a clinician. When we choose this clinical path, at least for me, I like to embrace a little bit of everything. I now try to embrace everything when patients visit my office. I rarely, actually, I don't remember the last time I referred a patient to another clinical colleague, to an endocrinologist, you know. I don't refer to a geriatrician, but I do refer to a nephrologist since I don't handle that anymore. Sometimes I'll refer to a nephrologist colleague to help me with the case, right? But this part of endocrinology, cardiology, geriatrics, anyway, even the metabolic part of orthopedics, I don't refer to the orthopedists. I'll refer if it's a fracture, if it's something like that, right? So when we have this clinical part and we choose to follow this clinical path, it's very interesting. It's interesting for us to know how to encompass everything and treat it. That was missing, you know? That was something that left a void, a really big gap in my daily practice.
I mentioned that just the other day. I think that has a lot to do, João, with a kind of Western view of medicine. By medicine, I mean all health specialties together. It's a way of seeing a patient in a fragmented way, right? So if the patient has symptoms of depression, they just throw in a serotonin reuptake inhibitor, an antidepressant. If it didn't work, I don't know, try a tricyclic, and it's all about medication, right? They usually see the psychiatrist. You're in pain, right? Joint pain, you go to the orthopedist. If you have a hypertension problem, you go to the cardiologist. And then after a while, this patient is taking 5, 6, 7, 8 medications, often some of them just to counteract the side effects of others. And it turns into that mishmash. And in Eastern medicine, it's a bit different, right? Is that what you just said? They already have a more holistic view of the person, right? They already have an idea of how the person works, that it's an environment that needs to be organized, especially Chinese medicine, which we're more familiar with. There needs to be a whole structure, and this structure has to be balanced. And many times the depression problem that the person has doesn't have anything to do with the brain. It's related to the gut. This person has dysbiosis and leaky gut, isn't making serotonin, so it's not reaching there, right? To give an example, and you mentioned something very interesting, which was the issue of cholesterol. I wanted to get into that a little bit since you're a cardiologist. We all get tests done, all of us. You get tests done, you do a checkup, right? Let's call it a checkup. And then there's the cholesterol, in my case, right? I got tested, and my cholesterol is now 247. There's the range. We'll discuss it later, since it's not exactly like that. Up to 190 is normal. If it goes over, my cholesterol is considered high. You go to I'm not saying it's everyone, but you go to a professional and they say, look, it's high, here it is, statin. Then you take statin, you get body aches. For the body aches, you have to take painkillers. Then you get a stomach ache, so you have to take the Prazols, and then it messes up your intestines. Sadly, it doesn't work. So you can't absorb B12, leading to depression and chaos because of unnecessary medication. So going back to this cholesterol issue, cholesterol, is it really that problematic? Does it have to be lowered at any cost? Is it a necessary molecule? What is the safe range? And what will really increase a person's chances of having a heart attack, a stroke, or a cardiovascular problem?
Look, actually, it's cardiovascular disease. It still hasn't been unraveled. The actual mechanism of the problem. I can say that now that I have 13 years of cardiology experience. I have a large number of patients. As I said, this is science. My office is science. And if anyone from the outside wants to say it's not, I don't know what, I'm not going to get into that discussion. But it's because it's experience. And I can
argue, but use science too, right? Exactly.
And I see, to this day, I'm still confused about what causes cardiovascular diseases. The interesting thing is when I opened my mind to other types of treatment, I saw that my options expanded. So we can see how that body is doing, whether that body is healthy or not. Because when you used to go to the doctor in the past, what was it like? Cholesterol, triglycerides, sodium, potassium, urea, creatinine, and blood count. That was usually it.
Blood glucose?
Glucose is
blood glucose.
Then came A1C hemoglobin, also in the middle period. That was it. And if that was in order, your health was good.
And almost everyone agrees, right?
If your cholesterol was high and you took medicine, it would return to normal. Everything was perfect.
Perfect.
And then when I started broadening my horizons with my studies, stepping away a bit from that more rigid kind of medicine, then we started discovering homocysteine, uric acid, which is gout. Gout causes inflammation. It increases the risk of cardiovascular diseases. Homocysteine, uric acid, high sensitivity, C-reactive protein as a marker, lipoprotein A, apolipoprotein A, and apolipoprotein B. Anyway, that started opening up a whole range of possibilities.
Ferritin, right?
Ferritin, when it's high, causes inflammation. I said, wait a minute. So now I can get a better idea of how this patient's health is. Because in the office, I saw that it wasn't just about lowering or reducing cholesterol to make someone healthy. That was already clear to me. And then we start studying biochemistry again. We start studying everything all over again. We go back to studying so we can apply that again in our daily lives. But coming back to cholesterol, when I started to open my mind about cholesterol, it wasn't so
evil like that.
I started studying medicine while working at the hospital because I loved its smell. I never expected anything evil like that. Today, I don't like hospitals anymore. Everything passes. When I started college, I'd walk into the hospital and think, wow, this hospital smells great. I want to work in a place like this. And I worked for many years in the emergency room. I worked for a few years in the coronary unit, which is like an intensive care unit for the heart. Yes, it's called the coronary care unit, coronary care unit. It's a unit for coronary problems, so we only saw heart cases in there. I worked for quite a long time in a unit like that. The hospital where I worked already had everything integrated and the system in place. So we updated everything in the hospital system. And that patient who had already been there, he was in the system. And when he came back, we would get his history from the system. So since I worked in that coronary unit, many times I saw patients who had already had a heart attack, who had been there 5-7 years ago, and after 5-7 years came back because the disease had progressed. It has progressed. Sometimes he had an artery that became blocked over those 7 years, or sometimes it was already blocked. He put in the stent and the other one got blocked. After 7 years, that stent began causing problems. Anyway, by then my mind was more open, I was more aware of it. So I evolved. That patient had taken cholesterol medication since discharge.
Exactly, taking it properly?
Exactly, since he was discharged 7 or 8 years ago. That was already part of his routine, his usual prescription. I used to say this patient has good cholesterol. He's been on statins for 7 years, but still got clogged arteries.
That can't be.
That can't be. If this medicine is really that miraculous, right? If it's really that good.
If it's really that good, right?
If it's so great, why is it blocked again? Got it, thanks.
A red light went on, right? Something's wrong.
It's wrong, it's wrong, it's wrong. And since we work a lot, right? We work a little extra.
We work more and more.
We work a lot and often operate on autopilot. So we just go there, do the work, do everything right, but we're not going to question things too much. Oh, was he already taking simvastatin? Let's keep him on simvastatin since he had a heart attack. Even if his cholesterol is very low, like 80. No, but he already had a heart attack. He has to stay on simvastatin because if you take him off simvastatin, he's going to die.
This protocol is still in the association, right?
Exactly. Had a heart attack, stopped simvastatin, there's no life left. Had a heart attack, it's forever. It's forever. And sometimes they even overdo it, right? Sometimes you'll see a patient with cholesterol as low as 80. We can discuss those details later, but when you talk to the doctor about medication, that's called polypharmacy. The patient is like a walking pharmacy.
A shoebox full of medicine.
A shoe full of medicine is polypharmacy. So what happens then? I realized we sometimes prescribed unnecessary medication. I often see polypharmacy in my office now. I remove unnecessary medications.
Stop at least half of them?
No, seriously, right? And he already gets a lot better just by stopping those things. That's it.
Especially elderly, right, brother?
He keeps taking a bunch of things he doesn't need. And the other colleague just prescribes more for him. He kept taking the other doctor's prescription to the new doctor, but I didn't. If I think he shouldn't take it, he won't. He's paying for my consultation, so he should listen to me. What?
To be evaluated.
To be evaluated.
In a holistic way, as we said.
It's not because he's taking it from his colleague. I don't want to override the colleague's conduct. That's not it, right? But I removed the medication that I think shouldn't be used. He's paying for it. He is, right? It was recommended by someone today. 99% of my patients come by recommendation. I have Instagram and internet access.
We'll go over this at the end because
all doctors should definitely have this.
All doctors should have.
This is the future. Everyone communicates through social media now, and we're helping people, right? When we bring information, I like to make some videos. I'm not that consistent, but every now and then I have an interesting system that I like to do because that way we end up helping people, right? And when a patient visits my office, simply reducing their medications often leads to good results. So we have to understand, guys, that medication is good. Yes, I do use medication with my patients. I sometimes use medication for depression when other adjustments haven't helped. Then I say, see, this tiredness you're feeling is actually depression. If you're depressed or anxious, they'll help you get out of the storm. They're prescribing the antidepressant. The patient is hypertensive, so I'll prescribe the medication.
Yeah.
Of course. So I'm a doctor who prescribes medication, but I'm a doctor who doesn't like polypharmacy. We're going to use it when necessary, only what is really needed.
And often we even stop it later, right?
Many patients who once took several medications now sometimes use none.
Yeah, no. For example, you gave a serotonin reuptake inhibitor. At the beginning, because it was acute, you had to, right?
Depression.
You make the adjustment, right? Many times, sometimes the gut is dysbiotic, you probably, right? You reduce and treat inflammation. Sometimes it's just B12.
Low B12, low iron.
Low iron, iron.
Low folic acid. Increasingly, psychiatrists prescribe folic acid or methylfolate.
Perfect.
I've noticed this and have been prescribing it more often. I see that folic acid really acts on the brain in several interesting ways. Sometimes folic acid is low. We check folic acid levels, but prescribe methylfolate, right?
Methylfolate, yes.
We measure in the acid.
Because then you give a better homocysteine.
Yeah, exactly.
Still turn it down homocysteine?
Exactly. I often measure folic acid and see levels like 3, 2, 4, or sometimes above 30. So the patient is anxious, feeling down and depressed. We give folic acid as methylfolate, right? With B12 optimized and iron, other things, adjustments with thyroid. He already says, Doctor, I'm great.
It improves, and you can stop the medication.
Several times. Sometimes we stop it later, so that's it. You need close follow-up, and you have to order tests, guys. When I say this, I see it a lot, Moacir. A criticism today is that doctors are more concerned with criticizing other colleagues to gain visibility on social media, you know? I see that a lot.
Yeah, it's happening more often, okay?
He doesn't use the internet to share interesting information. He uses it to criticize.
To do reactions, right?
You get it, to do those silly little things there. Sometimes the doctor... The other day I had an endocrinology conference, and there was a fellow doctor walking around the conference with a little microphone asking people, what gives you the most chills when a doctor,
I've seen them before.
an integrative doctor orders a test?
Increase vitamin D.
Increase vitamin D?
I saw it, I already saw it.
One person even suggested routinely asking for insulin.
Oh, you are kidding?
No, the endocrinologist said that, to routinely request insulin.
He only evaluates blood sugar?
Look, what I see most often in the office is normal glucose and hemoglobin A1C, but with very high insulin.
Let's talk about this. I want to talk about this.
Yeah, let's talk about it after this.
This is crucial for diabetics.
This happens often. The patient's A1C and glucose are good, but insulin is very high, showing major insulin resistance, even though some endocrinologists criticize ordering insulin tests.
Perfect.
Right? So sometimes those tests we order, they all have a reason behind them. We don't just order tests for the sake of it. We review each one in detail with the patient. We'll discuss A for A and B, why. Also, what happens if D changes. We'll discuss insulin, which is high. He doesn't know what insulin is. Recently, I saw another patient. You know that, interesting, there's type 1, type 2, and type 1.5 diabetes, right?
Oh, there's the 1.5?
The 1.5 later. If there's time, I won't explain what 1.5 is. Type 1.5 diabetes is the diabetes called latent autoimmune diabetes in adults. Why? What is latent autoimmune diabetes in adults diabetes? It's that patient who already has it around 40 or 50 years old. He usually has an autoimmune disease in the pancreas, but the pancreas isn't completely destroyed. Unlike in type 1 diabetes, which usually starts in childhood, adolescence.
It's congenital, right?
It's usually in children or adolescents, but can sometimes occur in adults. It's autoimmune, right? The body destroys the pancreas, so the person needs insulin. Type 2 is the opposite. It's often called the diabetes of laziness.
Bad habits.
It's laziness. The patient eats poorly and doesn't exercise, but then starts eating right and exercising. He gets out of type 2 diabetes.
I call it a cure, though diabetes has no cure, but actually it does.
Of course, I see it daily in my office with patients improving and moving toward a cure. They used to take Glyphage and other meds, but don't take anything now. Type 1.5 diabetes, or latent autoimmune diabetes in adults, is one of them. Latent autoimmune diabetes in adults is the most common. It's that patient who's around 50 years old who develops an autoimmune disease in the pancreas, but the pancreas still makes some insulin, not none, right? So you get a patient like this with insulin at 2.5 high glucose and high A1C.
Then you think, it doesn't make sense. They're not producing insulin.
So you don't order an insulin test. I already diagnosed the patient at the first appointment. Sometimes they've seen many endocrinologists who only treat his glucose and A1C, but don't order insulin tests.
It appears immediately,
And they don't order insulin.
even though it should be elevated.
They don't order insulin, but it should be high. His insulin is at 2 or 3. He produces it, but it's not enough insulin to handle that body. So the diabetes is type 1.5, and this has already been reported. Some doctors say they use this term.
They're using this term because type 3 is Alzheimer's.
That's the one related to the brain. But this 1.5 and 5, they're not from integrative medicine, okay? This 1.5 is actually from endocrinology.
It's registered.
But our colleagues aren't requesting insulin, so it's overlooked.
I think it's really important.
They're letting this crucial diagnosis slip by, right?
I want to make a quick comment on this exam issue. I want to address 2 points. First, this range. What do I notice? People go to get an exam, go for a checkup, right? There are people who get a checkup every year, so you go there to get your checkup. It's a blood count, blood sugar, total cholesterol, a bunch of things that aren't very useful, which will probably all come back normal. Then the person comes in cheerful saying, "Oh, I'm great," which means they feel free to eat and drink anything they want. This whole exercise thing hasn't impacted my life so far. And what have I noticed? When you look at these checkups, a lot of tests are missing. I mean, insulin, a good example, it's not checked, right?
No, not in any.
A for A for B. Almost no one asks for it. It's really rare. Homocysteine. Cholesterol is extremely dangerous. Everyone is terrified of it, but homocysteine, no one is worried about it.
No one asks for it?
No one asks for it. Glycated hemoglobin already indicates insulin, right? Glycated hemoglobin already asks for it. And you have, besides that, you have results that are within the normal range, which we observe today, but there's nothing normal about it. So here are some classic examples. How can an insulin test, for example, vary within the normal range from 3 to 23? That's not a normal range. How can someone have an insulin level of 3 and another person have an insulin level of 23? The guy who has an insulin level of 23, does he already have metabolic syndrome?
He already has acanthosis nigricans, which is that dark patch, right? The classic patch. Some people think that patch on the neck is just dirt or something, that the person doesn't wash themselves. No, guys, that's actually insulin related. Tim Meyer had that, right?
Tim Meyer had it.
Acanthosis nigricans can show up there.
Yeah.
He had it.
It's classic for insulin.
I have a childhood friend from Karakim I hadn't seen in years. When we met, he was really chubby. We're very comfortable with each other. You know, man, we never let things go. So when he arrived, we started teasing each other. And then later I was talking to him. Now, seriously, you have type 2 diabetes, you have insulin resistance.
I don't need tests. I can tell by looking at you.
Are you crazy, man? How can you say that? You have a spot on your face. Yeah, that's insulin resistance. Lose weight, and the spot will go away. That shows your insulin is high.
No, then it does. Maybe 21. Then he'll turn to you and say, "Look, I did it. It was 21. It's within the range."
It's within the range. I don't have a problem. There's no problem because it's within the reference. Yeah, so you have to sit down.
Yeah, but look at my concern about this. It's because you have a range that says it's normal, but we know it's not. And that goes for several tests. For example, insulin, we just gave that example here, right? An ideal insulin level. I don't know the standard you use there, but ideally, it's below 5.
Good insulin is between 3 and 5. That's ideal.
Below 5?
To work with the gold standard.
I did mine, it was 6. I was worried, but I figured it was just because I was returning from vacation. So it's there. Up to 23, it's normal. It's not. Vitamin D, it's above 20. It's okay. No, it's low. And the classic B12 at 300. My mom made it, man. My mom went to the doctor. Oh, my doctor is great. I love him. So, and my mom is having memory problems. Her thinking is slow and all that, sometimes crying for no reason. She gets tested and says, "Mom, B12 is 300. That's low." Then she said, "No, but my doctor said it's normal. It's within the range." I said the same thing too. I don't know what protocol you use, but a good B12 level is above 900, preferably.
In my view, a B12 level of 300 and something is a critical B12. In my view, it's critical. It's not even acceptable. Oh, it's low. No, it's bad. In my view, it's critical. Your B12 is terrible. Just so you have an idea, look, in Belo Horizonte, there's a lab there where the B12 reference was 111.
My God.
To 411, one of the city's most famous labs.
But it's because that's the lab average, right? They don't just decide, let's change it.
Gauss curve.
That's it. Perfect.
Curve of statistics.
That's it.
You just take people and calculate an average within that. Some people will be above 1,000.
Yes.
Some people will be at 100, but the average will be around 300.
But are the people taking the test healthy? In statistics, let's talk statistically. Of course, there are people taking the test who are healthy, but statistically speaking.
Today, it's about prevention, right? In the past, no, only people who were sick would get tested.
Now, maybe it's even getting better, yeah, but the people taking the test,
They have some kind of complaint.
they have some kind of complaint or they're older, already have something. So this average, it can't be considered normal. Vitamin D is a good example. For those who only get it today, so vitamin D, this average just tends to drop. And it worries me a lot. First, the patient doesn't even take it to the doctor, right?
It's in the reference.
Everything's normal here, right? I'll keep going and be patient, right? Everything's fine. I'll keep drinking, eating what I want, and not exercising. Even worse, if he visits the doctor says, "You're fine." How can we get out of this? Because this logic seems kind of silly, João, but what happens? Take the insulin example again. I was talking to a doctor last week and I spoke with her. Look, I have a view that the worst thing that can happen to a pre-patient, I'll call them pre-diabetic, but that patient who's already having changes in their blood sugar, it's for them to go to the health clinic and get a prescription for metformin and, gliclazide. The worst thing that could happen to him. Because in his mind, those two medications are going to help his diabetes or are going to solve his diabetes problem. And he's going to keep his habits. His life isn't going to change at all.
He's going to put all his hope in the medicine.
All in the medication,
That's just how it is.
So, and again, they don't even check insulin. Sometimes they don't even look at the A1C and they just do that so-called treatment, right? Because metformin won't help you. It improves insulin resistance there. Also, the cell is already full of glucose. It's going to push even more inside. It won't solve anything. Gliclazide, don't even mention it. This patient doesn't fit the integrative approach we discussed earlier. My friend, let's act. I'm not against medication, for God's sake. If you're taking it, metformin, don't stop. No, that's not it. But the most important thing in this example is for you to stop stuffing yourself with carbs like that. Is that why you're diabetic? And will that cure you? My dad is insulin independent. So what does he do? He eats sweets and raises his insulin. Because in his mind, of course, I've already explained this to him, but it doesn't help. He's already 80 years old. He's not going to change. In his mind, insulin is medicine. Because his blood sugar went up, he uses insulin to bring it down. If it goes somewhere, it doesn't dissolve but enters his cell. Obese, there's difficulty walking and everything here, besides glycation in the eyes, etc.
What controls insulin? Applying insulin is complex. And insulin, when it goes overboard, causes weight gain. Why does a person with type 2 diabetes also gain weight? Because insulin causes weight gain, right? Insulin also helps build muscle mass, right?
It does. Insulin really works if you provide the stimulus.
Sometimes you have an obese patient and weigh them using a bioimpedance scale. You'll see that they have a lot of muscle mass, really impressive muscle mass, but they also have a lot of fat. They have both, like a bodybuilder. They follow the insulin protocol to gain muscle mass, insulin below 3. All of this is a universal law. Everything is about balance, right? Insulin below 3 will also make you lose muscle.
Yeah.
I'm tall, right? In my teenage years, they used to call me sausage, right? At that time, if they had measured my insulin, it would have been 2. I've seen very tall, lanky patients with low insulin levels, but that doesn't mean they have diabetes. Sometimes the pancreas really does produce it.
It dropped to 2.5 because I was often fasting for 24 hours.
And then it dropped too much.
It dropped too much.
You have to be careful, otherwise you lose muscle mass.
You lose muscle mass?
Because insulin is also anabolic.
It's anabolic, yeah.
So we lose muscle mass, so we have to find that balance, right? So like insulin as well. I fast daily from Monday to Friday, but on Saturday I eat cheese bread my wife makes. But from Monday to Friday, I fast every day. For what? It's a mechanism for what? For controlling insulin. Because I stop eating at night and only have lunch. From about 8 or 9 p.m. until noon or 1 p.m. the next day, there's no stimulus for insulin production. The last time I ate...
That is wonderful, right?
It will fall, she'll stay quiet all morning, and then there will be an auditory stimulus.
Which is amazing, tell the truth.
Low insulin, high testosterone.
Yeah.
Low insulin, high growth hormone. So when you take a patient who's overweight and check their insulin, usually, it's not a rule, but usually their testosterone is low.
That's it. Especially because he's chubbier and will have more aromatase too, right? This already low testosterone will still convert.
Sometimes his estradiol is high. Other times it's normal.
It's normal.
Normal. He won't always be aromatizing, at least based on the blood tests, since those aren't always reliable. Since he has baseline testosterone, he's making some estradiol, right?
He was supposed to be aromatizing, right?
But it doesn't appear in the blood test, okay? But high insulin, low testosterone, then you talk to the patient, and low testosterone also makes it harder for insulin to work, right? Insulin too, then you talk, is a rat race. First come, first served. Is it the testosterone that dropped and made the insulin go up? Or is it the high insulin that made the testosterone drop? Usually it's the high insulin that makes the testosterone drop. And then when we lower that insulin, the testosterone goes up.
And that's such a vicious and perverse cycle that low testosterone also stimulates fat production.
Exactly.
In other words, you increased insulin, gained fat, and decreased yours. And growth hormone is the same thing, right? Growth hormone helps you lose.
Lower testosterone leads to more fat gain.
It's cruel, isn't it? It's like the diabetes cycle.
We have to break that cycle somehow. We have to break that cycle. So these details are important, right? That's why it's called integrative medicine and why it's important for us. Not many people discuss this.
That's the whole orchestra, right?
Look how things connect. High insulin causes testosterone to drop. Returning to B12, you mentioned that reference and the B12 from Belo Horizonte, which I called the lab several times. And I said, look, you guys are helping people get sick. Change that reference. Then they changed it from 111 to 411. I treated an acquaintance from Caratinga in Belo Horizonte who stopped by the hospital, went in and spoke. He said, you can do a computed tomography scan or a magnetic resonance imaging on me. I must have something neurological. I'm getting shocks all over my body. So what now? I went to the neurologist at our emergency room, Paulo. The neurologist ordered a magnetic resonance imaging, found nothing, and this guy feared multiple sclerosis. I'm telling the truth. I saw patients in Belo Horizonte from Caratinga. He went to a doctor's office. Do you know how high his B12 was? 150?
Yeah, there's no way.
The lab reference range was 111 to 411, and his B12 was 150. The doctor checked and said everything was fine. I said, come here. There's an infusion room at my clinic. He received a B12 intravenous already in his vein, 2 ampules immediately. I told you to send news in 2 days. João Paulo is finished. Nothing remains. The basics. The reference changed from 111 to 411. So what's the reference now? B12 levels between 250 and 950 are still critical, right? Even 250 is a lot.
Too low.
Just so you have an idea, okay? I was amazed by higher B12 levels. I give my patients 200, but I'm more aggressive and use 500.
No, but B12 is pretty safe because it has a reserve there in the liver, which is, we have a management of these reserves. K2, those oily ones, right? D is fine. A, D. The main question is, if it exceeds 100, insertion increases.
We'll talk about that too, because I'm not going to drop this myth.
There are controversies too, right?
I'm not going to debunk this myth. I really like vitamin D. He does too. I love it. Vitamin D, me too. Vitamin B12. My kids, ages 7 and 5, have loved B12 since they were little. It became a routine. And I collect the samples.
Keep high.
To see how much was their B12? 1,500 naturally. I was kind of like, okay, that's a little high. I don't know. Then after about 2 years, I tested it again and it was 1,000. So it had dropped a little. In other words, when we're young, look, the child is absorbing everything. Everything is working smoothly. The stomach absorbs well and everything is in harmony.
The acidity is fine, right?
The acidity is great, so we take B12. It works. We're getting older after all.
Intrinsic factor.
It doesn't have it anymore. It's not the same factor intrinsic, right? So kids in general, man, if someone has a B12 1500, why can't I have one? Recent studies show B12 is actually 200. If someone has a B12 of 1,000, I wouldn't tell them to supplement to 1,500. But if it's 600, if I supplement and it rises to 1,500, I like that. Hey, it went up here, look, but that's fine. It's great now, you know? So we have to use common sense. It's the best way for us to take care of our health. Everything that's good, we raise it up, and everything that's bad, we bring it down. That's metabolic optimization. It's simple. B12 is good, so increase it. Vitamin D is good, so raise it more. Ferritin is too high, it's harmful, so let's lower that ferritin. High uric acid is bad, so let's lower the uric acid, right? So when we find that balance, you transform the patient's life, right?
Uric acid is relevant to your case, right, Edgar? Look, I was talking to Edgar. We did one, he interviewed me here. Then we talked about uric acid as an inflammatory marker, right? Today, it's being used a lot as an inflammatory marker. Then I talked to him. There's just a lot. We used to learn, I don't know if they still teach this, that what raises uric acid is purine and pyrimidine, right? Heart, liver, etc. And you can...
The organ meats, right?
Yeah, the organ meats. Then he said that beer and barbecue meat are forbidden for him because barbecue raises uric acid. I said, hey, let me tell you something.
Just smell the beer.
That's what comes up. You want to know something? Uric acid, fructose, and you want to know where it is full of fructose? Processed food. Sometimes the guy doesn't eat fructose thinking it's fructose, but drinks soda, eats some chips, ketchup, condiments, everything has corn syrup, fructose. That messes you up. He said, man, I noticed before you even said anything, I stopped eating junk food. My uric acid, you actually had surgery, right? Almost, right? Nobody figured out his problem until an old lady asked, hey boy, don't you have high uric acid? 4 orthopedists. Look at that. 4 orthopedists. This boy was about to have surgery.
That's why I don't refer patients to the clinical side, that's why I take care of it myself. Because that's what happens. My colleagues are neglecting this part, this clinical side of things. So, uric acid is basically what all of this shows. When you talk about uric acid, guys, it's sugar. When we talk about sugar, it includes fructose, it includes everything, right? That's it.
Fructose.
But it's also bread, it's pasta, it's carbohydrates. So what is it?
Including cholesterol too, right?
Cholesterol too. We're going to talk about that. Everything is a marker of insulin resistance. Uric acid is also a marker of insulin resistance. High uric acid. There are patients. I often notice this with cholesterol. Individuality is beautiful, but let's return to this topic and discuss it later. That bar regular with a big hard belly, you know what I mean, right? I didn't notice your belly, but the bar regular with the hard belly, I would call, who hangs out with the whole crew there at the get-together, right there. That's the one I dealt with quietly. Where does his uric acid crisis mainly come from? From beer. Beer, in the end, it turns into sugar, guys, because it's a carbohydrate, because it's liquid bread, right?
And besides that, alcohol is also inflammatory. It doesn't help either, right? It doesn't help either, yeah.
Alcohol and carbs in drinks often affect those who overconsume alcohol, which eventually turns into sugar. And you talked about all of this, right? About sugar in general, about soda, about ketchup, right?
Processed and processed foods.
Processed, so it's not about cutting it out. You take this patient and put him on a carnivore diet, all the pain goes away, the uric acid will drop.
He improves when he eats only meat?
Yeah, carnivore. If you put him, he'll be like a jaguar, eating meat every day and nothing else. Yeah, stop sugar and the gout crisis ends.
Speaking of a carnivore diet, I saw this 2 weeks ago, an amazing study. I thought it was amazing. That's still ongoing. They did something really interesting. Back to cholesterol. It's an important topic, so we keep discussing it because there are a lot of myths. People are really afraid. I think they are. They took 2 groups of men of the same age, under the same conditions. Healthy, low inflammatory markers, healthy diet, exercise. Both groups. The control group, they raised his cholesterol through the ketogenic diet because the ketogenic diet tends to raise cholesterol a bit. So the cholesterol, the average reached 250, 260, 270, high by the standards considered by cardiology. And this group here wasn't, and with low cholesterol. So the only difference between these 2 groups was that this cholesterol was high and this one was low. But this healthy one is also healthy. 5 years went by. There will be 5 more. The study will last 10 years. Then they measured the artery using tomography, angiotomography. Results, evolution of both groups. Same thing. In other words, what we're studying about high cholesterol didn't impact at all what you mentioned, what you observed there at the hospital. In your case, the opposite. The guy was taking statins, but his cholesterol was going up. So here's the question. Does this plaque increase because cholesterol is high or because this guy is highly inflamed? With insulin resistance, with inflammatory markers way up, and a terrible diet.
For sure. Look, just going back there for a second, I said integrative medicine is like this. We discuss many things at once.
And then one topic leads to another.
One topic goes off track, so sorry to those who are watching because we keep picking up these topics.
We keep editing and releasing the video here.
We keep releasing it.
Try to organize it.
The endothelium is the vessel's inner layer, correct? It's consistent throughout the body. And I don't really understand why the protocol sometimes, the vascular people for the legs, is different from cardiology. Because the endothelium in the legs is the same as in the heart, which is the same as in the carotid, which is the same as in the cavity, right? Inside our vessels, it's the same.
A vessel is just a vessel, right?
Legs, belly, heart, and chest all have vessels. They're in different places, but a vessel is still a vessel inside. So cardiovascular disease, vascular disease, what is it? It's an inflammation inside the vessel. It's inflammation of the endothelium. What causes the endothelium to become inflamed? A million things.
It's a million things.
And then when the endothelium starts to get inflamed, to get hurt, who comes to heal it?
Cholesterol?
Cells cholesterol, among other things. So if you have a cut on your skin, you need to have healing in that cut. There's an aggregation of cells, right? It even forms a scab. First, there's fibrin, right? And then it comes and turns into a scab. The same thing happens inside the endothelium. Something passed through there, it got hurt.
And it has to be repaired.
And it has to be repaired. The problem is that sometimes the toilet is so small that when you go to make that repair, you end up clogging the toilet, the repair itself. The repair is meant to help, but it ends up causing issues. So what causes this endothelial injury? If you stop to read, there are a million studies talking about bacteria. There are studies talking about protozoa. There are studies that talk about viruses. There are studies that talk. What does too much glucose in the blood do? It damages the endothelium.
Glycation.
Glycation.
Yeah, the AGES.
That's right. Receptor for advanced glycation end products. Anything damaging the endothelium?
Protein spike.
Spike protein. Exactly. So anything that damages the endothelium causes endothelial dysfunction, which leads to cell aggregation at the site and causes blockage. So if you talk to a dentist, the dentist talks much more than the mouth doctor. I actually examine my patients' teeth, not just open their mouths and look. Sometimes I request a high sensitivity C-reactive protein test from my patient, which we like to do. It's a non-specific test. It even lists cardiovascular risk on the exam, right? If it's above 3, the cardiovascular risk increases. That's high risk. But from 1 to 3, it's medium risk. Below 1, that's ideal.
That's it. That's it.
I like a high sensitivity C-reactive protein below 0.5. High sensitivity C-reactive protein isn't specific to anything. The patient visits my office with high C-reactive protein, is sedentary, not exercising, and not doing well. So I continue to monitor him. When he starts exercising, C-reactive protein usually decreases. There, in that test, high sensitivity C-reactive protein shows that physical activity is inflammatory. Because my patient has a C-reactive protein of 3, 4, 5, 6.
He's inflamed.
He's inflamed. When he starts exercising, he gets less inflamed, and the C-reactive protein goes down. That returning patient was a bit late. Doctor, I exercised this week, but my C-reactive protein hasn't changed. I'll keep monitoring. Like that patient who says, I've changed my life, doctor, I'm doing everything. If C-reactive protein is elevated, what will I check first? Mouth. First thing. It's spot on. Doctor, but my dentist has been with me for 20 years. 6 months ago, he said everything was great. It's not.
This everything is great. That's very dangerous.
It's not because you're already thin, your health is regulated overall, you're exercising, but your C-reactive protein doesn't go down. Then he goes back to the doctor. I already tell the dentist, I say, I don't want a panoramic x-ray of the mouth. I want a computed tomography scan. X-rays can't see cavitation. Cavitation is an inflammation that usually happens in a tooth that has already undergone some implant procedure or What's the name of the other one with a dead tooth that gets a root canal? A tooth has either a root canal or an implant, and cavitation is painless. It doesn't cause pain. Some people have bad teeth that don't hurt, yet we often link bad teeth to pain.
Pain? Yeah.
No, it's not a rule. Then the patient goes back to the dentist and says, hey, my cardiologist is bothering me because my C-reactive protein isn't going down. He wants a computed tomography scan. Boom, cavitation. And what does this cavitation do? It produces inflammatory cytokines. That sends signals at a distance, and right there at the site, there's inflammation. So much so that the high sensitivity C-reactive protein increases. The high sensitivity C-reactive protein.
Oh, if you measure interleukin 6, it'll probably be high too, right? Interleukin 6 levels will likely be high too.
Elucine will be high. I suspect that sometimes in some people, even the erythrocyte sedimentation rate increases just a little.
Yeah, right?
Even the erythrocyte sedimentation rate. So going back to endothelial dysfunction, dental problems can cause endothelial dysfunction, guys. They can release those inflammatory cytokines. They get into the bloodstream and they damage the endothelium from a distance, right? So cardiovascular diseases, the problem goes much deeper. It's not just about cholesterol. It's not like that patient is going to fix their tooth and I'm going to save their heart. It's not like that. But I'm removing an inflammation that can cause a series of problems.
Because we are exposed to an inflammatory bombardment, let's call it that. An increasingly intense inflammatory bombardment, right? Ultra-processed food, even the healthiest person, if they come here, they end up consuming alcohol. I don't drink, but alcohol causes inflammation anyway, right? You have more and more excess free radicals, right? I joked the other day about vitamin C. How much vitamin C should you take? I said, look, that number isn't really a consensus. But one thing I can tell you much more today than 40 years ago, because what are you exposed to in terms of free radicals? And this vitamin C ends up being completely used up to fight free radicals. There won't be enough left to make collagen. There won't be enough for immunity, right? So it's more and more each time. So it's like you said, it's not that it's going to save you, but the more you can reduce this inflammation, the better.
You have a normal C-reactive protein here, up to 3, let's say, and then you have a new C-reactive protein. Do you want to stick with a real C-reactive protein?
Nobody wants that, no.
You know there's an imbalance there, right? So, like, C-reactive protein is also a marker of inflammation that can lead to cardiovascular diseases. So I see C-reactive protein as something that's out of balance, right? And when you start physical activity, it goes down. So it's very interesting that physical activity, the way we can prove it's anti-inflammatory, is through a C-reactive protein test.
It's all good, all good. You sleep better, you sleep well. Then your testosterone goes up, your testosterone rises.
We end type 2 diabetes with physical activity.
And stop eating junk food, right?
Yeah, both.
João, I wanted to talk a little about supplements, since that's your area, cardiology. There's a doctor named Dr. Steven Sinatra. He created a quartet that he called, or is called, right? The Sinatra Quartet, which is the coenzyme Q10.
The ribose.
D-ribose, L-carnitine, and magnesium. He calls it the Sinatra Quartet.
He's Frank Sinatra's cousin, right?
He's Frank Sinatra's cousin? Really?
Steven Sinatra is Frank Sinatra's cousin for...
As you can see. So he's even twice as famous then. Yeah, it's that book, The Cholesterol Myth, is by him, right? It's an amazing book. I recommend it for easy reading. It's not complicated at all. So he presents this quartet, right? If you supplement, and then he suggests supplementing directly without stopping, these 4 supplements, in your opinion, for cardiovascular protection, supplementation, let's call it mandatory because, for example, I consider some to be mandatory. Tamino D. Everyone is low. Magnesium, even if your levels aren't low, it won't harm you. Never, never. Because you have a reserve in your bone tissue, it will never harm you. Are you taking omega-3? No one is taking omega-3 or 5, right?
Which fish has omega-3?
It doesn't have it, and so on. In your view, then you can even extrapolate, right? This xanthine and I don't know. So I want to hear from you, in your view. Supplement? The guy who wants to have a heart like me because I'm going to live to be 120 years old. I don't know if you know that. The guy who wants to have a heart until he's 120 years old. There are other things to handle, but let's focus on supplementation. What do you think is most important?
That's a hard question to answer because it's like we were talking about here, cardiovascular disease is very
Multifactorial.
very tricky, right? I'm going to get into something controversial here. Yeah, it's not that controversial, but I think my colleagues are doing it wrong. The patient goes to the office, he goes there and gets an electrocardiogram.
Right.
And the electrocardiogram, he looks at it and says, you don't have anything in your heart? No, great. First,
Just from the electrocardiogram.
just from the electrocardiogram. First, 50% of electrocardiograms are normal at the time of a heart attack.
My father,
There you go.
the first time he had a heart attack, he didn't really have one. He called and told me what he was smoking, saying, when I drag on a cigarette, my chest hurts. I said, because blood vessels don't heal themselves, right? Whoa, then, I said, but I did go to the doctor in Porto Seguro, though I won't name them. Then he said this. He did the electrocardiogram. It came out normal. He had taken 2 atenolol, which is a beta blocker, right? He took his medication. The electrocardiogram was normal. He was already undergoing ischemic process.
With the electrocardiogram normal.
Yeah, he didn't have a heart attack, but he was already going through ischemic process. He arrived at Biocor where we brought him, and it was already 99% blocked.
Just a tiny thread of blood was getting through.
Yeah, only a thin thread was getting through.
He didn't have a heart attack, right? He went to Biocor and they put it in.
He didn't have a heart attack. He didn't have a heart attack.
Normal. 50% of electrocardiograms are normal during a heart attack, so this electrocardiogram is normal. When I worked in the cardiology emergency room, I saw that. Later, people came in with chest pain. Sometimes you can tell someone's having a heart attack, so you stay close. Other times, chest pain could just be anxiety, since anxiety can cause chest pain too.
It gets really confusing anyway.
An anxious world, panic disorder. You see someone and ask, are you having a heart attack? I used to tell the girls who helped there, hey, don't take the electrodes off the chest.
Keep them on.
The little pads, right? Leave them alone because every 4 minutes, we're going to give an alert until I get it. Why? What's the protocol? Send them to hemodynamics for catheterization only if the electrocardiogram shows elevation. If it doesn't change, don't send them. If the electrocardiogram is unchanged, admit and treat as a non-elevated heart attack. If elevated, it's an elevated heart attack. Sometimes I would catch a heart attack on the 5th electrocardiogram. So the patient comes to the office. I don't even do electrocardiograms in my office, but sometimes we do an electrocardiogram and say that everything is fine with his heart. I'm being irresponsible.
It's like the case of the guy you gave metformin to, the diabetic one, right?
I'm being irresponsible. Then he says, João, in the stress test, it's the same thing. 50% of stress test results are false negatives.
False negatives?
So do you like stress tests? I order it. Why do I order a stress test? I'm going to see if this patient develops hypertension during exercise. And I check if he has any arrhythmias during exercise. That's important. He sometimes has a conduction disorder, which could cause a fatal arrhythmia during exercise and lead to death.
Soccer players deal with that often, right?
A lot, not just with soccer players. Many people sometimes do strenuous activity. During the stress test, if he agreed, he sometimes noticed he went into arrhythmia. And if he's having some arrhythmia during the stress test, it's an indirect sign that he might be ischemic, since ischemia also causes arrhythmia. So why do I order a stress test? To assess my patient's functional capacity. If he gets arrhythmia or any abnormal ventricular activity during exertion or anything unusual on the stress test, I have concerns. If he has a ventricular extrasystole, a benign arrhythmia, that catches my attention. I order a test. What will the heart ultrasound echocardiogram show? It will show the muscle, it will show the valves, and it will show me the great vessels, the aorta, the larger vessels. The echocardiogram doesn't show the coronary artery. It's a very thin vessel. There are indirect signs on the echocardiogram that can show ischemia. Sometimes there is a change in contraction, a segmental change, as we say, but it's rare to happen. It's not a rule. Sometimes, like your father, he could have a coronary artery that's 90% blocked. You do an echocardiogram on him, and the echo comes back normal. So working in cardiology used to be very complex in the past. Because you work with electrical tests, which can give false negatives, you work with medical testimony, which can give false negatives, and you also work with echocardiograms, which can give false negatives. How do you slam your hand on the table during the appointment and say, go ahead, your heart is great? Only if you do a catheterization. But how are you going to stick a wire in and do a catheterization on everyone?
You can't.
You just can't. It still exists, not just in the past, the scintigraphy. In my case, which is a very good test, one that I requested a lot, it's a test that indirectly shows ischemia. If you have ischemia, there's a change in the pattern on the test. It gets kind of blurry, but you don't see the vessel, you see it indirectly. And there's something I've seen a few times in my office. When the patient has all three main heart vessels blocked, the scintigraphy, this balances out the scintigraphy, so the image comes out all the same.
It gives a false result, right?
Just that he's trivascular.
I see.
He's at risk for a heart attack in all three vessels, but it later comes back normal, balancing things out. Today there's a gold standard test. He did it at 60. I ordered it. Angiocomputed tomography and coronary. It's a non-invasive test. And it shows me the vessels perfectly.
Which is the test from the study I mentioned, the one ordered specifically to measure plaque?
Exactly. There in Beludon, there's a doctor who has a way. He gives me the plaque percentage.
What exactly is it?
The anterior descendant has 20%, right? Coronary 70, 99%. They're going for a catheterization then.
Yes, then catheterization.
Understood? So medicine, guys, the machine came to evolve. And our colleagues are stuck back there. The Sovereign Clinic is great, but not in cardiology. Not everyone has chest pain. There are several office patients who had nothing. I ordered a coronary computed tomography scan, and they placed 5 stents. Suddenly, he nearly died, but didn't feel a thing. And another very important thing, we always focus so much on chest pain. Chest pain. There are many things that don't cause chest pain, right? Many heart problems cause fatigue instead of chest pain. Patients sometimes say, I used to climb stairs without getting tired, but now I do. You can also check the coronary arteries. Then he visits the lung doctor, but they find nothing. You do a coronary computed tomography scan, and it's already obstructed because there's no oxygen demand, the heart doesn't function well, and he gets more tired. So cardiovascular disease is a very complex thing. So me, João Paulo, I set a rule in my office. When someone turns 60, regardless of symptoms, we do a coronary computed tomography scan to assess their condition. But I'm already wanting to narrow it down. I want to bring it to you for you to think about.
Yes, yes.
I want to bring it to you for you to think about. Have 55.
I'm almost at the time to do it then.
I forgot about the coronary, but do the coronaries clean. You stay calm for 10 years, then miss one exam like this after all that, you know? You can also check using the carotids, perform a carotid duplex, abdomen detachment. The vessels are clean with no plaques. The chance here is also not there, it increases. If it is there, the chance here also increases. So, usually I start my cardiovascular screening with the coronary, abdominal scan, carotid scan. If the aorta is clean and the carotids are clean, the chance that the coronaries are also clean is higher. But that's not a rule, okay? So we in cardiology, we have to know this very well.
It's an investigative process.
Exactly.
Like I always say, when you go to a healthcare professional, there are 2 things I keep in mind and that I always tell my followers. Look, doctor, you're around 70 to 75 years old. Are you experiencing any symptoms? Your memory is failing, right? You're feeling tired, some fatigue, right? Slow thinking, but whatever the symptom is. And if the doctor tells you that's just because of your age, no, that's just because of your age. Change your doctor, change your doctor. Another thing that worries me is what happened with my mom, right? No, ma'am, you're fine. They just did the basic test, the checkup and blood count, but didn't say anything. No, ma'am, you're fine. A B12 like that, right? You're fine, ma'am, but it's obvious you're not fine, right? Difficult memories, slow reasoning, even slower movements, classic signs of, it might not be that, right? She also takes statins, didn't even need to, right? With her enzyme levels so low, and she doesn't even supplement, right? So there are these things. So these 2 things, that's just your age. No, you're fine. Those are the 2 phrases I find most dangerous.
Someone I work with, she got a diagnosis for her son of attention deficit hyperactivity disorder and autism, and that's okay. He might really have it, right? But what about basic tests? They already gave him the medicine.
A little bit of top-notch Van Vance.
The yellow prescription, but they didn't ask for the basics. I said maybe, but let's check B12. Thyroid stimulating hormone, T4, T3, and T2, not 16 yet. We're going to check the basics first. If the basics are all messed up, let's fix the basics. Improved? Great. If not, move to the next step. So how is it? Do you make a diagnosis of something if you don't ask for the basics? A B12. Iron stores? How is the thyroid working? And you already give a prescription with a yellow medication, so that's medicine.
You also cut off dairy and gluten from this kid, which usually improves things a lot.
Absurd. Maybe it's from the gut. They say a lot that our gut is our second brain, but that's old news. If you stop to think about it, what happens? The gut is the second brain. When people have an emotional outburst, what's the first thing they want to do? Go to the bathroom for diarrhea. We get some news and we immediately run to the bathroom. They communicate both ways from top to bottom and vice versa.
Yeah, 90% of serotonin is produced in the gut.
From top to bottom, from bottom to top. They're talking. So,
if things are messed up there, my friend, taking tryptophan won't help. It won't convert to 5-hydroxytryptophan. It won't convert, it'll just become something else.
When I started in integrative medicine back in 2014, I was already talking about this. Now even conventional gastroenterologists are talking a lot about it too. Yeah.
It's getting better, right? It's getting better. People are becoming more aware. I don't know if it's because of the internet.
What's causing doctors to change their mindset? It's the patients who follow some doctors on the internet and they already come to the office putting on pressure. If the doctor doesn't know about that subject, they already leave that doctor and go to another one who understands it better, you know? So the doctor himself is losing the market. He said, oops, I need to focus. It is B12.
I need to pay attention to that. How does that work?
The market wants this from me, right?
Yes, it's getting better. It's getting better.
The patients themselves are changing that.
There. Edgar, how much time do we have left, dear? 1 and 14? Do we have time for one more question?
We still have about 4 more topics to cover.
That's what I said. I was with Edgar. We had a chat here. Then we got into vitamin D. And I said, if we're going to talk about vitamin D in depth.
Wow, discussing vitamin D could take an hour.
Cheese bread, just about that, just about that. But let's just touch a little on vitamin D. Let's just touch a little on vitamin D. It's 2 things, that thing I told you about regarding that range, right? Vitamin D is great above 20. What's your protocol? How do you work on correcting vitamin D there? Do you think it's important or not? To always combine vitamin D with K2. Exactly why, with increased calcium reabsorption in the kidneys and intestines, circulating calcium levels rise. And without K2 and without magnesium as well, you end up increasing the chance of calcification in the arteries. Do you think this is imperative? Should we always use vitamin D with K2 from what age? And if it's really necessary, if it's interesting, and to keep this vitamin D above what level? And why use vitamin D? Because then the person asks, but why do I have to use it? Because they say that eggs have vitamin D, that fish has vitamin D. Isn't it enough to get it just from food? If I just get it, I don't know, once a week, isn't that enough? How do you work with this therapy using vitamin D?
Vitamin D. There was a time when I was a bit obsessed with it, you know? So I read a lot about the vitamin.
We all were.
I think it was one of the first ones that sparked that interest in me. If I'm not mistaken, 1/3 of our genetics is controlled by it, or 2/3 of our genes.
It's quite relevant.
It's quite relevant. So everything will benefit from vitamin D. Here's the thing about vitamin D. What am I thinking today, João? What's the ideal vitamin D value? I say, what's yours parathyroid hormone? Because that's how I'll know if your vitamin D is good or not, through the parathyroid hormone.
Vitamin D, when it enters the cellular level, signals to the parathyroid hormone.
So, for example, if I have a vitamin D level of 45, which actually happened today in my office, that's a relatively good vitamin D level, right? 45 is not the value I like.
I like it higher, but it's okay.
See? But it's not, today I saw a patient with a vitamin D level of 15, so, 45, I'm accepting it. The vitamin D was 42 and the parathyroid hormone was 45.
Yes.
So this vitamin D at 42, it's not that low. Why is the parathyroid hormone higher than it?
Uh-huh.
So just so I know.
It makes sense.
Did you get it? Okay, 42. So how do I increase parathyroid hormone? Increasing vitamin D.
Negative feedback, right?
I'll keep raising vitamin D, which will lower parathyroid hormone. What is the ideal parathyroid hormone level? Between 10 and 20, in my opinion. Below 10, the risk of calcification rises. So the parathyroid hormone fell below 10. Hey, that vitamin D is too strong. Lower the dose and let the parathyroid hormone go a little higher. So your risk of kidney stones isn't as high, blah, blah, blah.
No, and artery calcification is most concerning.
Right? Keep it between 10 and 15 and 20. Between 15 and 20, very easy between 15 and 20. And that's how I'll know how much vitamin D that patient got. But I can always, can I talk about the dose?
Go ahead, Yukon.
I always start with 10,000, at least for adults. My calculation is 200 international units per kilogram.
10,000 straight?
Straight. Vitamin D doesn't.
I take 10, sometimes 20.
I take 20,000 each day.
That's right.
Vitamin D doesn't accumulate. If you stop taking it, it drops.
It drops, yes.
Quickly. Yes, yes. Different from B12.
It is fat soluble, but it has a low accumulation capacity.
Very low. If you're taking a good vitamin D supplement and stop for 40 days,
It already drops, it's over, it plummets.
it plummets. In 40 days, it really plummets. I tell my patients this, but they keep taking it and even get blood tests while still on it. If you stopped for a month to get a blood test, you'd lose the reference. You get it? So what is vitamin D? I know discussing this is more complicated. Ideally, it depends on the hormone parameter. Why? Individuality. We work with individuality. Vitamin D, it is generally, I use 200 international units per kilogram. In general, I start
For prevention, maintain by starting at 10 and increasing if needed.
10,000 international units. What do I do?
Then you prefer intravenous if it's very low?
Intramuscular, right? I don't do that. What's another option? The patient has a vitamin D level of 15. What should I tell him to do? 600,000
600,000?
single dose. He goes to the pharmacy and buys 50,000. Each pill, take 12 at once.
Orally?
No, take 12 in a single dose. She'll go from 15 up to about 60 or 70, but she won't go over that. Mentioning 600,000 makes everyone nervous, right?
No.
Way too calm, guys, 600,000. I did this throughout the whole pandemic with my patients, new patients who came to see me.
And several studies came out during the pandemic that greatly improved the inflammatory process.
For me,
And we couldn't say that on YouTube. We couldn't talk about it.
because they would call you a denier.
And no, the platform would take it down.
Took it down. See how we live censorship? Look, I made a note, or fewer than about 100 patients during the pandemic, all ages, adults, okay? Obese people, especially those in their 80s, are at risk because both obesity and COVID cause inflammation.
Chronic.
The patient got worse. People, right? I put my name on Facebook and said, look, anyone who gets COVID can contact me for free assistance. I did that. Everyone who said, João, WhatsApp, I left my phone number, I'm with COVID, I said, cross the street, go to the pharmacy, buy 1250 Memax pills and take them all at once. None of them went to the hospital. No one, not even the elderly or overweight. With vitamin D, I also gave some other things like acetylcysteine, but I'm sure it's the vitamin D. And it had to be used before the heavy inflammation set in, right? Yes, because it blocked the inflammation.
It modulates inflammation, right? It is a modulator of inflammation.
So Moacir, since I use a lot of vitamin D with my patients, I see the patient had dengue, vitamin D drops. The patient caught a cold, vitamin D drops. The patient had COVID, vitamin D drops. Patients come to my office sick and I immediately ask to measure it. I see the results. So even if you use vitamin D every day, when you get sick, it will drop. So what can you do when you get sick? Even if you use it, get another booster.
Attack dose.
Start by giving an attack dose there because it will be used up and it will reduce the inflammation. Vitamin D is very safe. Up to 20,000 international units, it's very safe. From 20,000 international units on, then you have to keep a closer eye on it. Got it? So when a patient visits my office, takes vitamin D, and still has low levels, on average, between 10 and 20,000 international units per day. And then I get to know that patient as they come for follow-up. And then I don't know if you've ever heard of Cicero Coimbra.
A lot, I have.
I'm a fan of Cicero.
He might be the world's leading authority on vitamin D.
He's definitely the world's leading expert on vitamin D. I've watched a lot of Cicero's lectures, and I've been waiting in line for years to do an internship with him. Cicero talks about this a lot. 10 to 20,000 people can relax. And there was a time when he had an interview with another neurologist in Brasilia, a neurologist who was against vitamin D and he was in favor of it.
Oh, a debate.
The neurologist replied, but this study says vitamin D doesn't affect multiple sclerosis. Cicero then noted, but this study used 2,000 international units of vitamin D in his own way. But Moacir,
That doesn't even kill a cockroach, right? It doesn't even kill a cockroach.
my boys take more. Your 5 and 7-year-olds.
In Brazil, supplements are limited to 2,000, right?
Vitamin D can only reach 2,000.
It can only go up to 2,000. It's the law.
Did you get it? So vitamin D depends. To answer, start with 10,000, not 20,000. No, people aren't using 20,000. It's more or less by weight, you know? I go by weight, yeah, and it depends.
It depends on how low it is. If it's very low, you need a higher dose, right?
That's what I do. Loading dose, yeah.
You have to go in with.
I give a loading dose, leave 10,000 for maintenance, and monitor. Did the patient understand? What does the autoimmune disease do? People with autoimmune disease generally resist vitamin D's effects. So how did Coimbra come to these high doses of vitamin D? Because for him to get a parathyroid hormone level between 10 and 20, he had to use a lot to get there. So that's why he ended up with a very high dose, because he aimed for.
Yeah, he handles the doses and goes over 100 easily.
My cousin is treated by him and uses 300,000. He's been in remission from multiple sclerosis for years and is doing well.
Really?
I hadn't seen my cousin in years. He's well off and traveled worldwide with Rodo for multiple sclerosis treatment, but didn't improve. He went to Cicero, spent $300,000 and told me, João, you're a doctor, you won't believe it. I said I was a fan of Cicero Coimbra. He replied, really? He's great, and began sharing his story. He's in remission from sclerosis. He's about 18 years old.
Look at that. How amazing.
What about high-dose vitamin D? His wife, a nutritionist, and his ex is very open-minded. She told João, I think vitamin D is really important. Because he eats poorly, he's overweight, his estradiol doesn't even go up, and his testosterone is high. He talks and has many benefits, I'm sure.
But vitamin D, it stimulates testosterone, right?
Vitamin D is at 18 and testosterone at 70 or 80, testosterone goes up.
Yeah, it increases.
So between 10 and 20,000, a basic amount, about 10,000 international units for adults, okay? For children, it's around 100 to 150 international units per kilogram, which is the right dose for kids. I follow the dose and monitor parathyroid hormone. Sometimes parathyroid hormone stays high even with more vitamin D because it also needs to be activated. Magnesium and riboflavin, vitamin B2, help activate vitamin D and move it into cells. Sometimes, even with more vitamin D, the parathyroid hormone stays high. Sometimes there's a sign that the patient is also deficient in riboflavin because it's not easy to measure riboflavin in the blood. It's expensive, right? You see, so then you add some riboflavin.
And it's silly to supplement too, right? If you take too much, it won't work either.
No, I use riboflavin more aggressively. Don't settle for just 50 milligrams.
No 50?
70, 100. Sometimes vitamin D needs riboflavin to activate. But rice and beans is 10,000 for adults.
Perfect. João, it was a pleasure, man. Let's put your social media here, right? Put yours. I'm sure everyone already wants to book an appointment with João, right? Obviously, I think you guys will have a hard time scheduling, but he's going to leave his office info here, his Instagram, his address, if you want to leave it here too. Feel free, put your contact info there for the people who want to have a consultation with you. It's not just the heart, but overall health, right?
So I'll just say the contact here, okay?
You can say it.
My Instagram is Dr. João Paulo Cimini Lille, which is my first and last name. Cimini is spelled with a C, right? C-I-M-I-N-I. But I think if you search for Dr. João Paulo, there aren't many Dr. João Paulo.
No, but it's good to put it there, Edgar.
Dr. João Paulo Cimini Leal, can you find me there? You can call a team for me there.
Call João. He always answers immediately.
Yes, you can call me there. A team will help.
The problem is scheduling. Okay, guys? The problem is scheduling the appointment. But go with faith.
We always find a way.
Say that you saw him here, okay? Right here, okay? Saúdecast, I just watched Saúdecast, so I get priority for an appointment there.
You can talk to the Saúdecast staff. I'll even give you a discount.
Look, I'm telling you,
I'll give you an incentive.
whoever following Moacir Rosa only has advantages, guys. It's all advantages. Look, guys. Who doesn't follow me elsewhere online? First, you should follow João Paulo's Instagram, right? Go do it. And here you are on YouTube. You don't follow me on Instagram. You're on Instagram, but don't follow me on YouTube. You're on YouTube and Instagram. You don't follow me on TikTok. You have to follow me, guys. And soon, look, let's go. We're launching an amazing product. For those who want to use social media, who want to use the internet, who are health professionals and want to make their social media more dynamic, I'm going to teach you how it works. We will have episodes every Thursday, and I will always invite someone. It's tough to find anyone here on João's level, but we will make an effort to bring people with different perspectives. We will bring people who talk about nutrition, about hormones. We will try to bring the top references in Brazil when it comes to health. Exactly for that. So you can have more energy, more health, improve your longevity, do the same. João and I are going to live until we're 120 years old, right, João?
Let's do this together.
You'll be at my 100th birthday, right? I'm not going to celebrate my 120th birthday, but I will celebrate my 100th. And I want to go to your 100th too, okay?
For sure.
João, thank you again. It was a pleasure and a privilege to have this chat with you.
And let's leave an open invitation here. If people liked our chat and they start asking for it, we'll sit down here again.
We will.
And they will have another 10 hours of conversation.
We break it up, we separate it. I won't talk about a specific topic, but this one here. You have to follow me on Instagram. You have to follow me on TikTok. And you have to follow João on his Instagram, because we're going to release clips from this material here, guys. So there will be some shorter clips. Whoever wants to see the full material, it will be on YouTube for a short time. On my channel, soon there will be a specific channel for Saúde Cash, but for now, go check it out on my personal channel. Thank you very much for staying with us until now. And don't miss our next episode. See ya then, everyone.